Welcome, everyone, and thank you very much for joining us at lunch today for this event. I'm Katie Grady. I'm the Dean of the Brandeis International Business School. I'd like to start first by thanking our co-sponsors of this event. The Israel Initiative at the International Business School, and the supporters, especially the donors that support this initiative, and the Perlmutter Institute for Global Leadership at the Brandeis International Business School. So today's event is a webinar, and we will take questions later on in the program. We are certainly living in turbulent, uncertain times due to the continuing global COVID-19 pandemic. As you probably know, we moved at Brandeis all undergraduate and graduate courses online back in March to ensure everyone's health and safety. But beginning earlier this month, we started the scaling up process with the reopening and repopulating of our science labs with researchers. Right now, we're in the midst of planning with our COVID-19 task force, putting together a plan for the upcoming fall semester that ensures a positive learning experience for everyone and their safety. So today, we'll talk a little bit more about the steps that are being taken, not here, but in Israel, as the global community all sets very different paths to end the quarantine and return to normal daily life. So I'm pleased today to be joined by our International Business School professor, Blake LeBaron, who will be moderating the discussion. Professor LeBaron is the Abram L. and Thelma Sachar Chair of International Economics, and he's also our director of the Master of Science in Business Analytics program. He is a renowned researcher in the field of agent-based modeling and time series econometrics, especially as applied to finance. I'm also very honored today to have a member of the International Business School's Board of Advisors, Dr. Orna Berry. Dr. Berry is known for her efforts to promote excellence in entrepreneurship and innovation with a focus on Israeli society. She's been a researcher, entrepreneur, policymaker, and corporate executive. Recently, she chaired the Research Infrastructure Telem Committee, which was established by the Israeli Academy of Sciences, building the National Program for Quantum Science and Technology. She is currently chairing the Telem Committee, defining the National Program for Research and Development in Artificial Intelligence. She has also in the past served as Chief Scientist and Head of the Industrial R&D Operation for the Israeli Ministry of Industry, Trade, and Labor. Thank you, Orna, for being here today and for your significant support of the International Business School, including being the architect behind this event. I now want to hand it off to you to introduce Professor Waxman, our featured speaker.
Thank you very much, Katie. I want to introduce a guest speaker, Professor Eli Waxman, who was born in Israel. He earned the Bachelor of Science in Mathematics and Physics and Master in Science in Physics, both summa cum laude, and a doctorate in physics, all from the Hebrew University in Jerusalem. During his graduate studies, he served as a research physicist in the Israel's Negev Nuclear Research Center. From 1994 to 1998, he served as a member of the Institute of Advanced Study in Princeton, New Jersey. In 1998, he joined the staff of the Weizmann Institute of Science. He served as the head of the Particle Physics and Astrophysics Department and the chief scientist of the Israeli Atomic Energy Commission on leave from the Weizmann Institute. Currently, he serves as the director of the Benozio Center for Astrophysics, as director of the Schwartz-Reisman Institute for Theoretical Physics, and chairman of the board of the Pazzi Research Foundation. As an Israeli leader, Eli applied best scientific practices to mitigate and halt the spread of COVID-19 in Israel. Eli has built an expert group to advise the National Security Council and the Prime Minister on measures to contain the spread of the virus. We are honored to host him in our event today. Eli, thank you very much for speaking to us. The Zoom is all yours.
Well, I'll do a quick intro, very fast. Thank you. This is Blake LeBaron again. Thank you, Dean Grady and Dr. Berry. And Professor Waxman, I think we are all just very happy to have, thank you again for coming. And we are just thrilled, want to hear what you have to tell us about how you and your team have been handling this most critical of global crises that we're facing, unfortunately facing today. So the Zoom window is yours.
Okay, thank you all for joining this event, and thank you for inviting me to talk to you. I will share my screen to start the presentation. During the past few months, I've had the privilege to lead a team of experts that advised Israel's National Security Council, try to illuminate some of the main aspects of Israel's response to the pandemic. We've started working during the middle of March. At that time, there was a very rapid rise in the numbers in Israel. The daily new cases rose from about 40 to 150 in 4 days, and the government therefore decided to apply a lockdown. So severe restrictions on social distancing, reducing the activity of the economy to about 30%. At the background, there were grossly contradicting assessments by various experts, both from the academia and from the health administration. For example, regarding the risk, some arguing that the risk is very low, that corona is just a flu with public relations, and some argue that the risk is very high, that we are facing thousands of deaths and tens of thousands of ICU intensive care unit patients. Another major argument was about the number of unidentified carriers. Some experts said that most of the virus carriers are identified by our PCR test infrastructure, while others argued that there are tens of thousands of unidentified carriers within the general population. These contradicting assessments led to contradicting recommendations of action, of course, starting with the lockdown, some arguing that it is crucial for the suppression of the pandemic, while others arguing that it is redundant, either because there is no risk or because many people are already affected, the unidentified, large number of unidentified people are already infected. So maybe we should just let a much larger part of the population get infected and develop antibodies and therefore achieve herd immunity. There were arguments about the healthcare system preparedness, some arguing that we need to prepare for tens of thousands of ICU patients, while others arguing that we should take no special steps. And there were arguments about the PCR test policy. Our policy was to test symptomatic carriers. The goal was to identify the carriers, to trace their contacts and isolate them, and hence to cut off the infection chains and thus contain the pandemic. If the number of unidentified carriers is large, this methodology would not be successful. And those who argue that there are many unidentified carriers were supporting random survey PCR testing of the general population in order to identify the true prevalence that they argue is much higher than we think. In view of this fog of war, I proposed to the NSC to construct a team that would be able to provide reliable status assessments and forecasts to assess the possible effectiveness of various actions. Based on that, to recommend the preferred action policy, and also to identify gaps in our ability to implement the policy and the steps that are required to close these gaps. We have constructed the tools for quantitative assessments of the situation that enabled us to to suggest decisions with a high level of confidence. Fairly quickly, we realized that we should not rely on models. And I'm sorry here, Blake, but we decided that all the models are based on rather unsubstantiated assumptions, and they include many unknown parameters. And our chosen strategy was to rely on data analysis of available world data, and I will say more about this momentarily. We formed the team very rapidly in order to be in time for the required decisions. And we based it on experts that have long experience with analyzing complex systems based on noisy data, which is the crucial part of the problem. I will first describe our status assessment, forecast, and recommendations of March 25th, and then I will explain how we reached these conclusions and recommendations. So the first point that we clarified is that the number of carriers in Israel were in the thousands, not in the tens of thousands, and that most of them were actually identified. This implied that the pandemic is under control, both in terms of the numbers of the carriers, in terms of our PCR test capacity, and in terms of our ICU capability. We predicted that social distancing would lead to a significant and clear decline in the growth rate by the end of March, and that the daily number of new cases is expected to start declining about 7 days later. And based on this, we also estimated the total number of infected people at the end of the confinement phase, which would be about 10,000. And we also predicted that the number of ICU patients would be well below 1,000. The implied recommendations were that we should maintain the lockdown until early April to see the decline in cases. We estimated the capacity which is necessary for testing based on the numbers of carriers that we have estimated, and recommended to maintain the focus on testing symptomatic carriers for the cutoff of infection chains and avoid surveys. The main gap that we have identified is that the time that was required for completing the testing and contact tracing phase was too long to be ineffective to enable a chain cutoff, and recommended to immediately increase the contact tracing capacity. We emphasized that we should avoid all the variants of herd immunity, which will bring catastrophic results. And we also commented about the public communication aspect, which is crucial for handling a pandemic and which was largely lacking in our view. So let me explain how we reached these conclusions. The first question we had to address was the fraction of asymptomatic carriers. If the fraction of asymptomatic carriers is large, this implies that there is a large number of unidentified carriers because we only test the symptomatic ones. This would imply, as I just mentioned, that cutting off infection chains would not be efficient, and maybe that we should move towards the herd immunity policy. We have shown that the asymptomatic fraction is small, it's less than about 25%. At the time of the report, this was based mainly on two lines of evidence. One, the exhaustive tests that were carried for the passengers of the Diamond Princess cruise ship, which showed 18% asymptomatic. And more important even, by the successful containment of the pandemic in South Korea, you can see that they have reduced the numbers of daily new cases by more than an order of magnitude by applying this chain cutoff policy without a major lockdown. Had there been a large population of unidentified carriers, this would not have worked. Today, we have much supportive evidence, and we know that the asymptomatic fraction to be low, for example, based on the testing of the cruise of the Theodore Roosevelt and Charles de Gaulle aircraft carriers and other lines of evidence. But at the time, this was a debatable issue, and it was an important goal to get the correct answer. Then we asked, is it possible that we may be missing most or many of the symptomatic carriers because our test capacity is insufficient and we don't reach all of them or many of them, or we reach them too late. In this case, we would also be missing a large number of unidentified carriers. The answer to this question is no. And how do we know this? So the point is that during an outbreak, the total number of carriers can be quite reliably inferred from the number of ICU patients and deceased. This is because the numbers of the people reaching ICUs is large during an outbreak, and measuring this number, which is not missed because these people do get to hospitals and get tested. So taking this number and the fraction of infected that get into ICU hospitalization that can be reliably estimated independently provides you with an estimate of the total number of infected people. There is a small description here of this little calculation that can be done. I will not go through it for the sake of time. You can all go through it after the presentation, but applying these simple rules to Israel at that time concluded that at March 25th, we had about 9,000 carriers, most carriers identified, and the prevalence in the general population was low, about 0.1%. Next, I want to say a few words about making predictions without relying on models. We've looked at the evolution of the pandemic in many regions in the world, and concluded that the evolution is quite similar across the globe when you look at it properly. Our advantage was that Israel was several steps behind many other states in terms of the evolution of the pandemic. And this implied that we can assess our situation and make predictions simply by an empirical analysis of the data that we collected from other places. Of course, this required constructing a database and checking the reliability of the data and removing contradictions and so on. And of course, it required some clever analysis of the data, but this is possible. And I show you here one simple example. This is the cumulative number of identified carriers in Spain, Germany, and the US. And you see that prior to any social distancing measures, the evolution is similar with an exponential growth. This is a doubling of the number every 3 days, or a daily increase of about 30%. And once social distancing measures are applied, a clear suppression in the growth is seen within 7 to 9 days. Another, a bit more complicated example, this is the evolution with time of the daily increase factor. So it starts with 30% here in different regions in Italy. And the time is shifted such that 0 is the time of lockdown in all places. And as you can see, this daily increase factor begins to decrease after the lockdown. And 5 to 10 days after lockdown, it seems that all the curves are approaching some universal behavior, which is independent of the differences between these regions. Okay. So using these tools, we were able to make predictions for Israel, and the database predictions proved to be accurate. Here is a significant example. What you see here is the cumulative number of ICU patients and deceased as a function of time in Israel from the time of school closure, and this is the lockdown. And initially, you see the exponential growth. This line is doubling every 3 days. And you see that the worry was that this line is crossing Israel ICU capacity fairly quickly. So we were here and we made a prediction that this is not going to happen, that by March 31st, this line here, we would only reach 100 ICU patients instead of 300 had the exponential growth continued. and that eventually we would confine the outbreak with much less than 1,000 ICU. And you see that both of these predictions turn out to be accurate. Another important point to emphasize is what would have happened had we delayed the decision on the lockdown. So this is not a nice example, but a good example. What you see here is Lombardia, which is a region in Italy with a population similar to that of Israel, 10 million roughly. This is the cumulative number of infected people, and the time is shifted such that the zero is when both in Israel and Lombardy we had 400 carriers. And you see that initially the growth is similar. This is the doubling every 3 days. Now Lombardy had delayed compared to Israel its lockdown by about 15 days. And the result was that they accumulated 10,000 dead compared to 300 in Israel. Also, you can see in the bottom plot that the healthcare system collapsed. What you see here, the red curve is the number of people in ICUs, and it saturates at 1,000. This is simply the capacity that they had. On the other hand, you see the blue line. These are the deceased. And the number of dead crosses the ICU and continues to rise exponentially. So all the severely ill simply died because they were not treated. And this led to a significant increase also in the rate of mortality, which was about 3% instead of 0.7% when the healthcare system is properly functioning. Last point for this first phase is the issue of herd immunity. So why should we avoid herd immunity at all costs? In order to achieve herd immunity, about 80% of the population should be infected. For a population of Israel, this implies about 50,000 dead and more than 200,000 ICU patients, which implies, of course, a collapse of the healthcare system. Now, it is true that the mortality is higher for older ages. So one of the suggestions was to isolate all the 65-year-old people, all the people above 65 years of age. This is, of course, impossible because you would need to isolate them for many years. And so it's not practical. But even if something like this is possible, we would still end up with more than 7,000 dead and 130,000 ICU patients, and again, a collapse of the healthcare system. Now, it is important to emphasize that this cost is not unavoidable. It is possible to resume nearly full economic and social activity, managing the pandemic over a long time, keeping the prevalence low for several years until a vaccine is made available, and all this at a cost which would be orders of magnitude lower than these numbers. And I will explain how to do this in the next part of the talk. Now, this herd immunity policy was forwarded to the government by leading scientists, physicians, ministers, and one of the important contributions of our team was to remove this danger from the table. Okay, let us move to the second chapter. By the beginning of April, it was clear that the pandemic is being contained. We were here along this curve, and we started discussing our long-term goals. So where should we be in weeks and months for managing the long-term battle with this pandemic? So I will explain first what the long-term goals are, and then I will discuss briefly our suggestions for the transition phase, relieving the social distancing measures towards this steady state long-term pandemic management. And as before, I will first summarize our recommendations and conclusions, and I will then explain them. Our long-term goal is to have a nearly fully functioning economy and society in the presence of the virus, because the virus is not going anywhere. while avoiding the necessity of applying lockdowns that cause severe damages to the economy and the society. Now, relieving social distancing measures will lead unavoidably to renewed outbreaks. There is no way to avoid this. So how would we ensure that we can handle these outbreaks without lockdowns? So the key is to maintain a very low prevalence. This means the number of daily new cases should be at a few tens or less per population of 10 million. Such a low prevalence allows several things. First, it provides a safe environment for all parts of the population, those with and without risk factors. Second, it enables a rapid suppression of low well before a new lockdown should be applied. The key to being able to maintain a functioning society and economy without resorting to lockdowns in the presence of the virus was to achieve very low prevalence. So the rate of daily new cases should be a few tens per day or less for a population of 10 million. And this would provide several things. One, a safe environment for all parts of the population, those with risk factors and those without risk factors. It will enable an efficient, rapid suppression of outbreaks without resorting to lockdowns. And it would provide a high level of confidence for the healthcare system being well away from the danger of being overwhelmed. I would like to now explain why and how these are the conclusions. First, I will show you that this goal is achievable, and it is also guiding the policy of states that have coped successfully with COVID-19. These are mainly Southeast Asian countries. You see here South Korea, Taiwan, and Singapore. You see the numbers, the daily new infected in those states, and you see that they all keep them below 10 per million per day. So do we understand why this is the policy that they have adopted? And the answer is yes. So let us try to explain this. One of our main goals is to avoid overwhelming the healthcare system. And one of the key parameters that we should look at, it's not the only parameter, but the key parameter is the ICU capacity. So let's take Israel is about 1,000 ICU beds capacity. And by the way, the bottleneck here is not the ventilators, it's rather the medical staff required. Okay. Now, since an ICU patient typically stays there for 15 days, this implies that we should not cross the line of 65 new ICU patients daily, because this would get us to about 1,000 overall. And since about 3% of carriers reach ICU hospitalizations, we shouldn't avoid 2,000 new cases. We should avoid 2,000 new cases daily. Now, from our experience and from the experience of other places, during a rapid outbreak, once a lockdown is imposed, the number of daily new cases rises by about a factor of 20 before saturating. This implies that we will need to apply strong measures once we cross 100 new cases daily. Now, if we want to be sure that we identify with high confidence such an eruption crossing 100, we should stabilize at a steady rate, which is well below this, so at a rate of a few tests per day and normal. Now, these considerations also lead to two additional important conclusions. One, when we cross this number of 100 or so new cases daily, we will need to apply social distancing measures. This would be local measures instead in the case where the eruption, the outbreak is local. And it will need to be statewide constraints if the outbreak is not confined to a well-defined region. A second important conclusion is related to our ability to make sure that we don't have runaways. How do we ensure that with this level of 10 new cases per day, we don't have some diverging chain of infections that very quickly gets us to the hundreds? And the timescale for the evolution of this pandemic is 4 days. This is the typical infection time. This implies that we need to have the capacity to suppress any such new outbreak on a timescale of about 48 hours in 2 days. And let me say a few more words about this. So it is crucial to have the capability to suppress any eruption, any new diverging chain of infections within 48 hours. In order to do this, this means that we need to be able to test suspected carriers, confirm that they are carriers, trace their contacts, and isolate them. All this within 48 hours, from symptoms to first circular isolation in 48 hours. This will ensure that the chains would be suppressed and that we will be able to avoid runaways from the tens to the hundreds. On April 14th, we proposed to the NSC our long-term management goals and also our recommendations for the transition phase, for the phase of relieving the restrictions. I would say this very briefly only. Our guidelines were to carry out the relief gradually with 2 weeks intervals between successive steps. And this is because it takes about 2 weeks to assess the impact of a step that you have taken. And second, we emphasize that we should weigh risks versus gains for the economy of each of these steps. In particular, we should be careful about allowing activities involving gatherings of tens of people in closed spaces, which usually have little contribution to the economy. We have set what we've coined as the purple standard. These are regulations or guidelines for regulations for conduct at work in public places that will help reducing the infection probabilities. We recommended to allow full resumption of activity to places that meet the purple standard requirements, and we recommended using self-regulation rather than government, full government regulation. And finally, we emphasized that we must complete the construction of this capability of rapid test, trace, isolate within 48 hours in order to make sure that we have the tools required to suppress new outbreaks without resorting to lockdowns. And we stress that this should be completed before resuming high-risk activities like commerce and full-scale education system operation. What is the current status in Israel? So on April 16th, the government adopted our recommendations. This is the announcement of the Prime Minister's office adopting the recommendations. So this all seems fine. The problem is that the implementation was and is lacking. Restrictions were relieved too fast and not according to the value versus risk considerations. And a test, trace, isolate unit was indeed constructed, but it was not given the authority that it needs to manage the process, and therefore we do not have this required capability even today. And the results came after successfully suppressing the rates to the goal of about 10-20 new cases daily in mid-March. We see a rise back to the about 300 cases per day already today. The rise is slower than it used to be in March, but if this trend continues, we will face another lockdown in 3 to 4 weeks. So we must take action now in order to prevent this danger. Okay, I would like to end with some guidelines for action in the near future based on our experience, which may be relevant for not only for Israel. First, there is no herd immunity solution. As I've mentioned, the cost of such a policy would be catastrophic. 50,000 dead, 200,000 ICU patients for a 10 million population, and the collapse of the healthcare system. Our goal should be to maintain nearly normal activity of the economy and of the society in the presence of the virus, while avoiding lockdowns due to outbreaks that are bound to occur as we resume normal activity and the virus is still around. Achieving this goal is possible, provided several requirements are met. First, the prevalence should be kept low. Less than 2 daily new ICU cases per population of 10 million. This corresponds to about 50 daily new infected cases per day, but I emphasize the daily new ICU cases because this is robust. The ICU cases get to the hospitals, you can count them reliably. The number of newly infected may be misleading if you're not doing sufficiently wide testing of the population. Second, you must have the capability for a rapid cutoff of infection chains, 48 hours from symptoms to isolation of first circle of contacts. And in order to have this capability, you also need an adequate testing capacity of about 10,000 tests per day per 10 million. And one of your signs for a properly functioning testing infrastructure would be that the daily new ICU cases will be less than 1% of the daily new confirmed cases. Okay, because this is sort of the rate that we expect. Now, before reaching or prior to reaching this low prevalence requirement, you should maintain or strengthen your social distancing measures because it will not be possible to maintain a functioning economy and society with much higher prevalence. And here I want to emphasize that the economic, social, and health interests are not in tension. They are actually aligned. If social distancing measures are indecisive and do not lead to a rapid reduction of the prevalence to this level, this would imply that the economy and the society would be functioning only partially, and that the accumulated damage would be much, much larger compared to a policy where strict measures are applied to rapidly reduce the prevalence to this level. And second, it should be realized that maintaining normal functioning with high prevalence is impossible because recurrent lockdowns would bound to occur due to outbreaks that you would not be able to control. Okay, and I will stop here.
Okay, thank you very much. Actually, Eli, could you like shake your mic? Your sound was pretty good, but there was a little, occasionally some static. You might have like a slightly loose wire on your mic, so just do it like a little shake there. We could hear you, but but I think it should be okay with a little jiggle there. Yeah.
Okay now?
I can hear you now. We'll have to go with that, I think. I got a lot of questions coming in on the Q&A line, so I'm just going to go right. But Thank you very much. That was actually, for me, totally insightful into what's been going on. It's just a really nice, detailed overview of the policy and the responses and the work of your team. So just excellent. I'm very excited about that. But I want to get right to the questions here. So I have a couple. This may not be the first one. I'm going to do this sort of in the order they've come in. May not be directly related, but you may be able to just tangentially point to it. Someone was asking about Israel's activity, though, on the vaccine side. I think Israel has been active on that. Do you know much about that, or is that anything in the realm of your team?
Can you repeat the question? I didn't hear you well.
Just a very quick comment on the status of research into a vaccine going on in Israel.
So I'm not. This is really far from my field.
Yeah,
I know that there is a lot of work being done at both at the universities and at the biology research center, but I'm not really the person to ask about this.
Okay. Next question may be closer to back into your realm here, because it's about testing, and I've heard about this in the U.S. too. I've heard that Israel is working on checking for virus in sewage plants to see where the hotspots are. Do you know about this? And if so, can you review your thoughts?
Well, I believe that this is not going to be a useful exercise. The level of prevalence that we are talking about, these are like few tens or hundreds of people for a population of 10 million. The only way to identify carriers and outbreaks is by going to the carriers, testing them. Mm-hmm. All the other methods, heat maps, and all those things that were proposed are not sensitive enough. They become sensitive when the prevalence is so high that it is already too late. Mm-hmm. So the best, the most sensitive, the fastest indicator is the number of symptomatic cases that you test.
Mm-hmm. Next question that came in, I'll read this here. It actually, though, incorporates a bunch of geopolitical things too. It's Dr. Waxman, thanks for your service to the nation of Israel and to Jews worldwide. Do you attribute the success of these results in part to the country's constant existential threat as opposed to having to succumb to public opinion, political views? Do you think that this reality of existence that our nation lives under contributes to the seriousness with which security health initiatives get dealt with? Is this a factor, possibly a variable that could be accounted for in analysis?
Oh, yeah, interesting.
Big question.
Interesting, a big question. Okay, so I think that one of the unique things in Israel was the ability of the establishment to accept advice and help and assistance from many sources. So when the outbreak began, we had the many units in the army just going into the health ministry, proposing help and being incorporated in the process. The government was ready to listen to our advice and to the advice of other experts. So this was, I think, a very positive aspect. I think that unfortunately, it is true that we are used to dealing with security crises, but we are not so used to dealing with civilian crises. So I think that our infrastructure for dealing with this is not excellent. And what helped us was the ability of the system to adjust and accept help and assistance from a wide range of bodies and individuals. And I'm not sure that now that we are going into this long-term management phase that we will be doing as well.
Yeah, well, I mean, it is interesting. I think you do have a population that may be more willing to make sacrifices in this than in countries that are less threatened at times. Here's another more direct to compare you to other countries. Here's a question. What do you think about the Swedish approach designed by Dr. Tegnell from the Public Health Agency of Sweden, which aims to sort of at herd immunity?
Okay, yeah. This is what we call an excellent question because I have a slide. Showing
well, Sweden's out there. Obviously, they're doing their thing too.
Yeah, yeah. This is like, what about Sweden?
What about Sweden?
Yeah. Okay. So here's Sweden.
First of all, it's not clear what policy Sweden has actually adopted. There is discussion of herd immunity, but they deny that they chose this policy. In reality, there is social distancing being applied in Sweden, partly by the government, partly voluntarily, and they've reduced their activity by 40% for a long time. Now, what were the results? So let's see, this is Stockholm alone. In Stockholm alone, which is 1 million population, we have 1,300 dead, more than 1,300 dead already, which is worse than Lombardy. So 13,000 per 10 million population. The ICU capacity was saturated, as you can see here. And the worst thing is that there is no end in sight for this because they are not identifying most of the carriers and they will not be able to resume normal activity because there would be major outbreaks. So this is a good example for causing large damage over a long period of time with heavy costs on the economy and on the healthcare system and on the society, and not resolving the problem. Yeah.
Interesting. I'm juggling my order here, but I have a very practical question here. It seems apparent that travel to Israel is unlikely to be possible for many months to come. Can you forecast, I know forecasting is difficult, can you forecast when it'll again be possible to visit?
I heard only the last part of the question.
Oh, I can summarize that more quickly. When will, and there must be restrictions, there are restrictions on foreigners visiting Israel. When do you think those will get lifted?
So as you said, it's very difficult to predict. And now people are required to be quarantined, and I think that as long as the prevalence in many places is high, this would still be a limiting factor. I think that as long as in places where the prevalence is high, we would have to take measures to make sure that we don't import a large number of cases which are uncontrolled. Yeah.
Mm-hmm. So I have a question about, this is near and dear to my heart, on heterogeneity. You seem to treat the entire population homogeneously, but in reality, the impact is quite different by age. How does that impact the guidelines, especially for the young and school-aged?
I'm not sure what indicated that we are using, that we are treating the entire population as a single unit. So I gave rough numbers, of course, in this presentation, but all the numbers that I gave for the numbers of deceased and ICU patients are taking into account the distribution of ages in the population of Israel. So based on measurements in many other places and corrected to the age distribution. So it is true that mortality at a younger age is lower, but also at younger ages, not between 0 and 19, but between 20 and 45, the mortality is like 0.1%. And the fraction of people getting into ICU hospitalization jumps at the age of about 45. So this is not an old people's disease. It affects the entire population.
I've got another question that's related, so I'm going to jump it around here because it was also asking about schools again. There were some, right? There were schools led to large increases of people being quarantined. Has there been new policies on schools? So that's back to the school age types, as whether they are sort of something population we need to treat differently because schools, and we're worried about the same thing, obviously, opening up schools here. So we're kind of looking to your data, but I know that's been a recent event there.
Right. So we've seen major outbreaks in schools. I believe that we could have avoided some of this, especially the older students could have been kept at remote learning, and this would have allowed more space for younger grades, and therefore would enable reducing the rates of infections. So full resumption of schools is going to lead to outbreaks, and it should be managed carefully. Yes.
I think I'm going to have to, I may only have time for one or two more questions, so I have to apologize to all the, I have actually, we've been swamped with questions coming in, but here's one that's actually sort of, I think the numbers are right. I hope these calculations are correct. That asks, testing at 10 to the 4th per day implies greater than 3 years to test everyone. Is this acceptable? If everyone were tested in 7 to 10 days with positive quarantined and traced, as has been shown in other places, and all negatives retested in 7 to 10 days with positives again quarantined, COVID is stopped dead in its tracks. Sort of read that. I think it's.
Okay, so the capacity of test of about 10,000 per 10 million population per day is meant to enable identifying all the symptomatic carriers. So the policy would be mainly to test all the people with symptoms and identify those that are carriers of the virus. The number of 10,000 or 15,000 is derived from the background that you have when you have a regular flu. You need to test all the people with these respiratory symptoms, and you need to identify the 10th out of them who are actually coronavirus carriers. And this will enable you to do the contact tracing and isolation and suppress the eruption. There is no way to test the entire population and to there are many problems with trying to test the entire population. Just the numbers don't work, and the false negative is quite significant. It's 30%. So it's simply impossible to do this test everyone. And
I'm going to finish up one last question because it's interesting and it's also relevant to things we've seen in the United States. This has come in several forms. Whoops, moving around on my screen. How are Arab citizens doing, and particularly though, also how are poorer neighborhoods, poorer, maybe more congested neighborhoods? Are there differences in the spread of the disease in these areas? Do you have any information on that?
Yeah, so we see a correlation between socioeconomic level and the prevalence of the virus. It is not surprising. I think it is related to several factors. One is that the lower income jobs often require people to go out, and it's much more difficult for them to be isolated. And also there's less space per person. So the rate of infections within the neighborhoods is higher. So the correlation is clear. What should be done, I believe, is to provide the logistics required in these neighborhoods for them to be able to do an effective isolation as required. If you don't provide this logistics, it will be very possible for them to do it, and it would fail. Okay,
thank you. I have to apologize. I'm on on my time schedule, it's time for me to start wrapping up. So I have to apologize to all the other question askers out there. I can't get to your questions, but I would definitely then I think for all of us to thank Professor Eli Waxman for this just really fascinating talk. Thank you again very much on this. This has been a super interesting way to hear what's going on. Also to Orna Berry, of course, and to Dean Grady. Also, thank you for putting sort of a lot of this together. Thank our sponsors, the Israeli Initiative, Perlmutter Institute for Global Business Leadership, the International Business School. And I don't know if Gina is going to coordinate. The recording of this event will be made available soon on the Brandeis Alumni Association YouTube channel, which that will be I'm sure you can find that will be posted. Be on the lookout. I'm also give an ad for some other events that will be coming. So just keep checking out that website for other events. If you enjoyed this webinar, please join the Schusterman Center for Israel Studies on July 21st for Israel, the Pandemic, Economic Impact, Political Response, Social Conclusions. You'll see that link too. Whatever time zone, I know we're all across the globe here. This is what's great about Zoom. Stay well, take care. Again, thank you very much. This is very interesting. I am totally fascinated to say so. Thank you, and thank you to everyone for being a part of this.
And stay safe, everyone.
And stay safe.